infections, work package 9. Not everyone here is a regular member, so thank you so much for coming to this meeting. We're really happy that we can have this meeting. I'm very excited about it, and to share this with WHO as well, and some interesting work that Martin van der Eyden's been leading on, and Brenda Wanning from the Global Drug Facility. So super excited to start this meeting, and it seems like, okay, I think we start. So it's my pleasure to welcome, let's see here. It's my pleasure to welcome Oscar Yedelbayev. He's the Regional TB Advisor at the World Health Organization. Oscar's going to give us a quick overview of the TB situation in the EU and the EEA. Welcome, Oscar.
Mm-hmm. Thank you very much, Christine, and indeed, thank you, colleagues, for inviting to this important meeting and for your attention. So indeed, it's 40 people joining this call. It's showing a very high interest to the issue, and very glad to see the colleagues whom I know already. So I will share just like a few slides highlighting the epidemiological situation on tuberculosis and drug-resistant TB in the western part of the WHO European region, mainly representing 28 countries of EU, EEA, plus United Kingdom and Switzerland. So I will share the screen now, and just like to remind that the WHO is generating a global tuberculosis report, and it is coming out every fall around the month of November, and this report is accumulating aggregated data coming from countries all around the world on tuberculosis. So I wanted to explain that from EU EEA, the data to the global tuberculosis database are coming through the ECDC. So basically, this is indeed also a joint work. So last year, the report was showing out of 30 countries in western part of the region. All of them reported notifications on tuberculosis. Many of you have seen this slide before. So out of 30 countries, 21 reported an increase in notifications of tuberculosis in 2023 in comparison with 2022. So 16 out of this 21 who reported an increase, they have reported a more than 10% increase. And this is indeed a worrisome scenario because it is gradually increasing despite, in comparison with what we have seen before the 2022. So the 14.5 of these countries who reported, they also reported an increase in rifampicin-resistant or drug-resistant tuberculosis with or without resistance to fluoroquine alone. This is indeed a worrisome scenario, and for the western part of the region, because it is showing that the drug-resistant tuberculosis is indeed a health security issue, and it does not recognize as airborne disease any artificial barriers or walls. And 8 countries reported a record high numbers of rifampicin-resistant tuberculosis, and it varied from 13 to 75% in 2022. And many of those countries are indeed showing that the similar trend is happening now. I'm showing this slide. It's a preliminary slide that what we have for the 2024 data that will be released in the Global Tuberculosis Report. So far, because we are still not in the month of November when the report will be released, we have received notifications as of yesterday from 17 countries. Out of the 17 countries, 7 in EU, EEA, United Kingdom, and Switzerland. 7 out of 17 reported an increase in notifications in 2024 in comparison with 2023, so the trend is continuing. And 3 out of 8 reported more than 10% increase. I would like to repeat that this is the preliminary data. We don't have the picture of the all all 30 countries. But indeed, what is worrisome again is that 6 out of 17 reported an increase in the number of drug-resistant tuberculosis, and 2 of them record high numbers of rifampicin-resistant TB. So I do not have a privilege to disclose which are these countries. These are aggregated data. More information will come with the global tuberculosis report. But what I would like to say at the very end of my short intervention is that this is indeed an area that requires attention from the global and regional public health community, from the member states, from the ministries of health, and taking into account that there are people with tuberculosis and drug-resistant TB who require adequate treatment based on the latest international recommendations. So this gathering, this meeting today is quite important. And I also would like to say that we at WHO Euro, in collaboration with EU Commission, with ECDC, with member states, established after the 2 regional meetings, a coordination platform on improving access and availability of medicines for tuberculosis and drug-resistant TB. And I'm here on this call with my colleague, regional advisor on access to the medicines, Mr. Rasmus Gesing. And so we both represent WHO today, regional office for Europe, and this coordination platform is functioning, also given a space for the discussion, sharing the experiences. So please join us on the 2nd of October for the call, in which we will share more updates. Thank you.
Oscar, thank you so much. Can I ask, though, could you say anything about success rates, comparing a bit of treatment success rates in EU as compared to the greater WHO Euro? Is that possible?
Sure, definitely. I didn't put this information into slides, but the treatment success for multi-drug resistant tuberculosis in the WHO European region on average last year was 67%. Indeed, it's increasing, but it's still suboptimal as what we say. And in drug resistant tuberculosis, treatment success is being reported 36 months back for the cohort enrolled 3 years ago. This is the reporting timeline. So basically, what we had in the Global Tuberculosis Report 2024 is for the cohort of 2020. This treatment success was 67%. However, we are expecting in the an increase with gradual increase of the access to the medicines recommended for WHO and regimens, shorter regimens, fully oral for drug-resistant TB for later cohorts. And this year, 2025, will definitely show that. If we compare the treatment outcomes for the Eastern Europe and Central Asia, countries reporting really high treatment success rate, reaching and exceeding 85%. So for countries in Central Asia, for example, and even Ukraine, the country that is currently at the difficult situation, the treatment success for drug-resistant TB is much higher to what we observe in Western Europe. I do not recall the exact number right now, but it does not exceed a little more than 52%. So basically, a high rate of loss to follow-up, which means patients who defaulted or abandoned treatment. There is a substantial percentage of patients who failed treatment and died, but again, this is suboptimal. And of course, there may be some issues that are related to access to the medicines recommended now, and we have been discussing this for quite a while, but also for the modalities of service delivery, supporting patients throughout the treatment. And the current regimens that WHO is recommending are fully oral for drug-resistant TB and really short that are patient-centered and can significantly improve treatment success. So, I mean, offering this treatment will prevent further growth of the reservoir of infection in the communities. Thank you.
Thank you. That was excellent, Oscar. So now it's my pleasure to turn it over to Martin van der Heijden, who is a lawyer and pursuing a PhD at the London School of Hygiene and Tropical Medicine. He's researching global health, law, and governments, and he's been doing a lot of very interesting research. I've been lucky enough to be working with him on this. So go ahead, Martin.
Let me just share my slides. All good?
Perfect. Thank you.
Great. Yes. So this is a project that Christine and I started together with Ralph Otto Knapp. I think it's part of the EU-JAMRAI for Christine, but for the rest, it's an independent project that we just started on the side out of interest. But of course, it doesn't come out of nowhere. I think the EU, but also WHO, Euro, and MSF have been focused on this issue for quite a long time and done quite intensive research and also advocacy for raising the issue, which caught our attention. There's a lot of interesting data available already, including from the WHO Euro and from the new MSF report, Bridging the Gap. But where we try to take a different perspective is by looking at the official data available from the EMA and seeing how the current regulatory pathways influence access to TB medicines in Europe. Now, as Karin's presentation already showed the current situation, there's been a long trend of declining TB. There's a goal in 2030 to get rid of it altogether in a sustained manner. But there's an uptick, and if you look at the EU, of course, the EU is not a fully integrated medicines entity, but a group of countries working together on medicines through the EMA. There's a huge variance in the disease burden, and that is not only because of the country size, but also just limited by borders and for other reasons. And as such, you can see that some countries have very few cases, under 10, under which you could say that marketing authorization would be suboptimal from an economic perspective. But there's quite a few countries that have, especially for pediatric TB and MDR-TB, over 10 cases or over 100 cases. As such, there's real access questions there. The issue, of course, is that we have a large policy paradox. As TB incidence will decline, there will be a declining revenue or commercial interest, and therefore there will be less of possibilities to rely on marketing authorization for access. And that will lead to an impossibility of maintaining that decline in TB incidence. Perhaps we already see that trend, perhaps we just see an uptick. We have to see over the next years. But it also leads to suboptimal treatment, which arguably could lead to MDR-TB. Well, in this study, we looked at all the different access pathways in the EU. The top 4 are the marketing authorization ones. They have 3 exceptional pathways: the individual or compassionate use, emergency use, and the public interest authorization. That's mainly used for small island states like Malta and Cyprus. You have the parallel import and parallel distribution options. These are options that are created by the way that the EU is structured, in which there is a balance between the national competency or partially shared competency of health and medicines, and the EU competency over matters of trade of goods and services, under which there is possibility for trade in medicines as goods under certain circumstances, kind of balancing that right with medicine law and intellectual property rights. And then, of course, there's a magistral formula and official formula production. And I think in a previous report from the EMA, looking at pediatric formulations, it was already seen based on the member state survey that Article 5.1, individual use, and hospital production of medicines 3.1.3.2 were very heavily relied on for TB medicines. In this study, we mainly look at the public data, so the data from the EMA. Under Article 57, we asked for data on national registration of TB medicines. We also looked at data from the heads of medicines agencies databases that show data on Article 126A authorizations and the mutual recognition procedures that are possible in the EU. So looking at all this data, we can see that there's 3 types of TB products at the moment. Of course, the newer TB products that are centrally registered, the type 2 products that are nationally approved, and there's type 3 products that are not approved in any EU or EEA country. These type 1 products, they go from provisional approval to centralized approval. Centralized approval, of course, makes it easier to market these products, but these products are not marketed in every country. But there's a possibility for parallel distribution and trade in these products, and that's what is seen quite regularly in EU countries. Of course, some countries also use an exceptional pathway for these products, but that is rather rare. There's only few. I think the MSF report really covers this type of product very well. Then there's the type 2 product, generic TB medicines with national approval for at least one formulation in more than one EU EEA country. Article 57 data from the EMA doesn't show the formulation of medicines. And as such, it's not possible to see from the EMA data which formulations are registered in which countries, but it is possible to see which products are registered where. And as such, we've seen that most products are only registered in a few countries. Only the products basically from the RIPE or the ARZE regimen are registered in more than 10 out of 30 countries, often or more than half. And rifabutin is registered in over 10 countries for TB, HIV co-infection. These other products, and especially the fixed dose combinations, have very limited registration in the EU. And as you can see, there's also a rather large variance in the registration in EU countries. And even though this map looks kind of positive, perhaps for some countries, it is important to note that the dark blue countries only have access to 6 or 7 products out of 30, making that physicians only have access to a very limited arsenal of TB drugs to use through marketing authorization. And then there's a large number of products that are not registered in EU EEA countries, and from this we should thank PREDAP because we got this data from the TB Global Drug Facility through their market intelligence. And there's especially a large number of pediatric formulations that are not available in any EU country at the moment, leading to increased treatment failure. So that's a regulatory picture. What we can see is that marketing authorization is only a pathway for a limited number of drugs or a very limited number of countries. And as such, countries very heavily rely on the pharmacy production of these drugs, and especially on the named patient basis. In some cases, also on the emergency use of medicines. But there are structural drawbacks on that, especially that the named patient basis has some legal insecurities, that often it's only allowed to be imported per individual. And this is also what the European Court of Justice has said, but that these are finding ways around this. But we've seen litigation in countries that makes this pathway rather unsustainable. And a large issue with these exceptional pathways is also that the burden of administration, but especially also of responsibility for the use of these medicines, is shifted from the state to the clinician. And even though it's much harder to control the quality of these drugs, states increasingly push this responsibility onto physicians, which in our view is rather unethical, both towards the patient as towards the healthcare worker community. So as such, we've looked at the data and we've seen that there's very limited parallel trade within the EU on drugs, even though it would be possible. This is mainly at the moment because there's a lot of divergent rules, mainly for labeling, packaging, but also for the pharmacovigilance requirements that should be taken into account with parallel trade. And there's very low market interest. Parallel trade in products could be a solution because as we have seen, there are most of the products are registered in one or more countries, and as such, it should be fairly easy to buy these products from other EU countries. But the initiative lies with traders, and there's very limited economic interest at the moment to become a trader in these drugs. Also because parallel trade at the moment in the EU is very differently interpreted by country and is also shaped by the European Court of Justice. And as such, commercial actors do not really feel secure very often to use this method. The other main options that we looked at is a zero-day mutual recognition procedure. We're looking at the database of the heads of medicine agencies. Well, this has been introduced in March 2024. At the moment, there's very little uptake of this procedure. What this procedure allows for is that it is possible to for manufacturers to use a mutual recognition procedure, even though the dossiers may be outdated, if countries agree based on their assessment that the product can be allowed into the border. And especially designed for public health needs and low-burden diseases. We've seen that there's fewer than 10 TB-related mutual recognition procedures used by May 2025. And as such, there's very limited use of this regulatory pathway, even though it could be useful. But there's no... It's hard to say what is the exact cause of the limited adoption. It could be the lack of commercial incentive. Could be the lack of clarity on the countryside, whether they will accept this procedure. And then there's the individual special needs pathway, and this really accounts at the moment for a large part of the MDR treatments in the EU. And there's of course a lot of issues with this because the individual special needs pathway has both a very broad allowance for importation. It doesn't, the product doesn't have to be registered in another EU country, but can be registered anywhere in the world. And as such, there's not a European agreement or oversight for quality. And it only allows for individuals' special needs. And this has been regularly interpreted by the European Court of Justice, and it has also led to a lot of national litigation. Because at the moment, many EU EA countries pre-authorize unregistered medicines for bulk import to hospitals or clinics, kind of expanding the Article 5.1 interpretation, even though this has been shut down quite regularly by the ECJ. Countries are finding ways to get around this. So there's, we looked at different country examples, and we don't mention the countries because we have not had permission yet to mention them in the study. But there's various ways that countries go around this individual special needs pathway. Some countries use cohort-based ordering for hospital pharmacies. So they allow the pharmacy to go beyond this, not ordering based on request or for a physician based on a specific individual patient, but to allow for the purchasing of larger quantities directly towards the hospital pharmacy. Some countries allow for generic permissions via the ministry or the inspectorate, and some countries allow for bulk importations for FDCs in bonded or pre-customs warehouses. And this is kind of the only way that would be perhaps legally allowed, but the European directive and the regulations are not really clear on whether holding medicines in a pre-customs warehouse is governed by the regulations or not. So as such, you can see that countries are expanding the individual special needs pathway in many different ways, and it creates kind of a division between countries. Some countries are very strict in the way they interpret the European directive, and therefore suffer for accessing these medicines. And some countries take a very liberal approach and are able to access these medicines. But recently in the Netherlands, this type of argumentation was shut down by the National Constitutional Court based on European case law. And it's already visible that this is an issue for a long time. In the EU stakeholder report on the member state satisfaction with the current regulatory system, member states already said that the article was a lifesaver article for urgent public health needs. So it's completely essential because the public health emergency article only kicks in where there's a true emergency that is not really foreseeable. And proposals were already made to extend it to multiple or potential patients. So a cohort basis, or also being able to purchase for future patients, which is currently under the strict interpretation not possible. This is the case law that has been used on this, which argues that the only way that Article 5.1 should be used should be based on the doctor's request for an individual patient, and the derogations must remain exceptional and cannot bypass marketing authorization systems. So what are the solutions? At the moment, we are dealing with a system that basically requires marketing authorization or has very specific exemptions only for individual patients. And in our perspective, this proposal from 2021 is becoming increasingly urgent. Countries should be able to buy medicines for cohorts or for future patients in order to be able to treat diseases, especially for TB, but also for other infectious diseases. And we see this issue as well with antimicrobial resistance, where many countries do not have access to all antibiotics that could be useful for patients. And we also see treatment failure or increased resort to reserve antibiotics, even though other products could have been used. Exceptional pathways have become the norm, and also not sticking to the EU directive has somehow become the norm, and this creates this two-system approach within member states. The bonded warehouse system could be an option, and it could remain a possible option to create the ability to already import products before the named patient basis is used, if you want to adhere to the current strict interpretation or court's interpretation of the named patient access. And there's very significant opportunities for intra-market trades. There could be more reliance on each other within EU countries, and agreement to make intra-market trade more accessible, but that would require some I don't know if it would require a change in directive or regulation, but at least would require some agreement in the EU to accept each other's labels or to accept alternative label solutions. And the zero-day mutual recognition procedure is an option, but remains rather unused. The other option, of course, is to use financial incentives. And that is also what we've seen with the European Commission's tender. The issue with these financial solutions is that they are rather short-term. So we are still looking at this tender, and I have not seen the contract, but I'm not sure if Christine has. Maybe she wants to add on this. But the European Commission has recently commissioned a tender for the right to purchase TB medicines for 1,500 children for a period of 5 years. The manufacturer has to guarantee supply readiness, and the manufacturer has to do the pediatric trials and bioequivalence studies for these products. So 5 million for 5 years for 4 products or one combination is rather a lot of money, and it also doesn't guarantee that the manufacturer will continuously supply to all countries in the EU. Of course, there's a lot of benefit in this, in the sense that the product's clinical data and marketing authorization remains valid, allowing other producers to step in if this manufacturer steps out. But the cost of maintaining a European-wide marketing authorization for one product is quite high, around 800,000 to 1.2 million. So it has to be, it's very questionable whether this is profitable or perhaps whether the prices have to go up very much. And another question that this type of solution begs is whether this type of first marketing authorization doesn't create a 10 to 12 year or data market exclusivity for the pediatric product. We haven't seen the contract, but of course, if that is the case, it could create some kind of situation where there's no longer the 5-year guarantee to supply, but other suppliers cannot step in, creating a 5 to 7 year gap or issue around this. But it is speculation, not having seen the contract. But just to show that there's a balance between regulatory solutions and financial solutions, and that financial solutions are rather costly if you would allow them for all the TB medicines that we have listed in the study. Christine, and maybe you want to add something, because this is a common
I think
project ours.
Yeah, perfect. Thank you so much, Martin. Okay. Thank you. Thank you so much, Martin. That was the end. Yep.
Yeah.
Yeah. So thank you very much. That was excellent. I'm sure that everybody has a lot of questions for Martin. But before we do that, we're gonna, because this session's being recorded, we're gonna hear from Brenda Wanning, from the head. She's the head of the Global Drug Facility first, and then we're gonna open it up. We're gonna stop the recording, and then we're gonna open it up for discussion. So then you won't be recorded, and we can have a nice open discussion. So I turn it over to Brenda now, and I think.
Thank you, Christine. Let me
Great.
just, get my. You see this okay?
I see you okay. I don't see the slides though.
Oh, you don't? Okay, let's try this again.
Now I see the slides.
Okay, very good.
Perfect. They're not in presenter mode yet, though.
Yeah. Let me just click that on now.
Perfect. Thank you.
Okay, very good. Well, thanks so much for inviting me and giving me a chance to share a little bit about the Global Drug Facility. We call it GDF. So just a bit of an overview. We've been around for almost 25 years now, created by Canada and the US government way back in 2001 when there was no quality assured TB medicines available. We are a UN entity. We sit within the Stop TB Partnership in Geneva, and we're hosted by a UN organization called UNOPS. We're the largest procurer of TB medicines and diagnostics. We carry everything you could possibly imagine for diagnosis, prevention, and treatment, including over 500 lab items. We're ISO certified, and at this point, we have quite a global recognition, especially in low and middle income countries. But beyond buying, because we are created to promote access, ongoing continuous access for countries, and also to create a market, we do a lot more than just buying. So we really work to figure out what are the product gaps for TB, how do we incentivize suppliers to make them, and then how do we monitor them to make sure they don't get stuck anywhere, including in the regulatory system. Then we work with suppliers to make sure their production plans meet the global demand. We make sure countries have what they need by doing work in country. We support introduction of new products when they are recommended by WHO, and then when they're no longer recommended, we help with the phase out, which can be quite difficult for suppliers, as you can imagine. So our model basically is we post a global tender, and then all of the eligible suppliers can bid, and we make agreements with multiple suppliers so that we create supply security across multiple suppliers. Then we have a catalog. This is available online. You can see we're very transparent about the products we carry and the prices we have. And we have over 160 clients in more than 130 countries. They place their orders with us. We place them with suppliers who then deliver them to a bonded warehouse in the Netherlands, where we have just regular stock, and we have so we can combine multiple orders from multiple suppliers into a single shipment to a country. We also have our own inventory of a stockpile that you'll see in a minute. And then we deliver supporting all the importation needed and whatnot in our own packaging, which you see a not great picture there on the right, but that's GDF packaging in 4 languages. So the typical traditional procurement order is basically the country places the order. The pool procurement mechanism combines all those orders to get leverage on price, submit to the suppliers, and then suppliers deliver to the countries. GDF is a little bit different. I won't go in this in detail, but in the middle here, you see in the black, you see we get the order from the countries, and then we assess it. And we look at how big is the order, how urgent do they need it, what's the supplier production plans, what's the in-country stock situation, and if it's a if it's a manageable volume here down on the bottom of that gray box, if it's a small volume and it's a short lead time, then we basically just deploy it from our stockpile. The SRS is the strategic rotating stockpile. If it's a large volume and they don't need it for a long time, then we send it to the suppliers, they send it to our warehouse, and we deliver it to the countries. If it's a large volume and they need it right away, then we can split the order. We can say, okay, we'll deploy some from our stockpile and some from the supplier directly. And this is, the stockpile has been really key, especially with averting stockouts, but also introduction of new products, think like delaminid and bedaquiline, where the initial orders were often less than 5 treatments per order. And definitely for our high-income countries where the volumes are just very, very small. So these are just the supply trends to give you a sense of how large we are. Last year, we bought about $350 million worth of products. We delivered last year about just over 3 million treatments of drug-sensitive TB medicines. And this is a trend of countries. In 2024, we delivered TB products to over 160 clients in 126 countries, buying with all sorts of funding, of course, donor funding, but also 50 countries bought with government funding. We had 9 high-income countries buy from us last year, including EU, EEA countries. And we supplied 14 clinical research projects who all have subjects in high-income countries. So if you look at the size of the EU EEA market compared to the global demand versus GDF demand, here you can see that the EU is just a tiny, tiny percent, less than 1% of people treated globally. Luckily, that's a good thing in that you don't have big TB epidemics, but it's bad in that it's hard to get suppliers to consider that as a viable marketplace. And then if you look at the EU EEA demand as a percentage of GDF procurement, I should have changed this. It should be 1%. It's about 1%. So if you look at, we supplied about 3.2 million treatments last year. If we had supplied every single person who had TB in the EU EEA, it would be about 1% of our demand. So just not a lot of incentive for suppliers to market here, especially for generic products that rely on volumes, as I think was pointed out by Martin earlier. Especially important is you can see for drug-resistant TB in kids. Here I'm talking about children less than 5. Most people report children less than 14, but we break it down into children less than 5 because these are the kids that want the pediatric dispersible tablets. A 13-year-old kid does not want to use those products. And if you look at how many kids are treated per year under 5, it's only about 750 kids. But despite that, we've managed to convince the suppliers to make all the medicines needed for DRTB in kids in child-friendly formulations. And these are the formulations we have. Martin had the list on his slide as well. But you can see here the most common that are available through us that are typically missing in EU, EEA, and all high-income countries really, is rifapentin for prevention, all of the child-friendly dispersible formulations, and here's all the products we have for DRTB for kids, and then the fixed-dose combination formulations in the correct dosages, and also available in pediatric formulations, as you can see on the right. So we really are a one-stop shop. We have literally every medicine optimized in the right formulation as recommended by WHO. And then this basically just shows you of the number of, these are the number of suppliers we have for the different categories of drugs, the number of formulations for the different categories. And you can see that of all of our medicines, only 19% are actually registered in the EU, EEA. And then you can see the categories of products that are currently procured via GDF from EU, EEA countries. So we are able, because we have a lot of services and tools that I don't have a chance to go into, but we have a lot of ways to keep prices down with suppliers by decreasing their transaction costs, for example, through our stockpile, through our labeling, et cetera. And because we are the biggest buyer, we guarantee the lowest prices worldwide. It's in the contract, so suppliers cannot give anybody a lower price than us. And many other countries and UN entities benefit by using our prices when they negotiate their own prices. Over the past 10 years, we've achieved price reductions up to 98% on medicines and diagnostics, and some examples of big price reductions in 2025. You can see these are new from the last time I presented to the EU group. So we had big decreases in all of the medicines for BPOM. So you can see bedaquiline now is $63 a treatment, protamid $169. Linezolid $27. We actually have people buying linezolid from us for non-TB because it's virtually impossible to get it at that price. Moxifloxacin is $24, so that brings the BPAL price to $254 and BPOM to $289. And we do keep track of the savings that we offer to our clients from all the different things we do to save them money. And we estimated in the past 10 years, we saved over 400 million for our clients and donors. And then this is just the full list of our current prices per regimen that have been updated. So you can see for prevention on the top there, 3-HP is $10, 1-HP is $18. And then you see the pediatric 3-HP, 3RH and 3-HP prices there. Then our DSTB prices for adults and kids, you can see 47 and 33 for kids. And then these are our current prices for the most commonly used DRTB regimens for adults and kids. The red regimens are new, recommended by WHO just this year from the NTB and BEAT-TB studies. And all of these have been adjusted downward based upon all of the price reductions we got for the BPOM medicines. So that's it. Maybe just to highlight something that Martin said, because I thought that was an excellent presentation, is that, you know, what we've learned is that it's one thing to incentivize a supplier to develop a formulation and to potentially register it in a country that wants to use it. That's not even half the battle, because you're typically dealing with such low volumes in countries. You have to find a way to make sure that that very low volume medicine is where it needs to be when it's needed, when the majority of your orders are going to be just a fraction of the batch size that the supplier will make. And so that's why our stockpile has been so critical. We frankly couldn't serve pediatrics, even in our market, if we didn't have that, because we're constantly rotating that stock through the system to make sure that, you know, in the alternate scenario without a stockpile, country A puts in an order, not enough. B, C, D, E, F, still not enough. A supplier is not going to make that batch until they get to, let's say, 75% of their batch. Then they make it. Now you're waiting 2 months. And now you've gone, you know, stock out. So really thinking through not just how do you incentivize people to develop, but then how do you maintain a supply chain on an ongoing basis when everybody's needs arrive at different times to make sure they have what they need. Suppliers don't waste product, lose money, and become no longer interested. Yeah, thank you very much.